in this lecture is first, how can the immune system detect invasion by pathogens and alert the immune system rapidly? You need to have like first responders. How does the immune system do this, and how does it have immunological triage to know this level of infection is extremely minimal, we don't need to bother the T cells and B cells to mobilize, or this is a really serious infection, we really need to recruit B cell and T cell help. How does that occur in the immune response? And the question is, well, yeah, B cells and T cells are really cool because they have these sophisticated T cell receptors, antibody receptors, but is there another way of doing it that's low tech? And as we all know, sometimes low tech is even more effective than high tech because it's simpler and less things to go wrong. So can we develop a low tech system, a quick and dirty way to differentiate pathogens from self-antigens and mount an incredibly rapid immune response? And this is a cartoon just to kind of illustrate the problem the immune system has. And again, I apologize if it's not politically correct. But first is that the immune system, to do pathogen profiling, has to have a certain level of sensitivity. It has to be able to detect that something is wrong. And in this cartoon, it's someone who's supposed to look like a terrorist saying, there I was driving bin Laden, minding my own business with a couple of missiles in the trunk, and they never even read me my Miranda rights. And the point is that this clearly, they should have picked up on this, something was wrong. There was no sensitivity in this screening. And the flip side is you need to have specificity. You need to pick the right amount of response against the appropriate, if there's an infection. And this is a cartoon showing the scene of the Magi, where the three wise men come to the birth of Christ. And, well, yeah, they are of Arab extraction, but clearly they're there for something very important and very good. And yet here you have the American Attorney General back at that time saying they look Middle Eastern, detain them. Again, you need to have specificity to really determine what is wrong, and the immune system has exactly that same issue to deal with. So how does the immune system contain pathogens? You know, once there's an infection, you need to rapidly be able to contain the pathogens. And how are immune systems directed to the sites of infection? If you have an infection, for example, in your finger, well, how do T cells in your lymph node know to get into the circulation and get out at the right location where the infection is? If the inflammatory cells don't go to the right location, they're not going to be able to help you at all. So clearly you have to have a mechanism to allow you to direct the effector cells to the appropriate site of infection. So it all starts with the initiation of an inflammatory response. Now, does anybody here pick their nails? Anybody here pick their nails? Nobody? You can admit it. It's not like it's this horrible vice. You know who bites their fingernails? Okay, so you bite your fingernails. Have you ever gotten an infection from biting it? Exactly. It happens all the time. And in fact, this is exactly what has to happen during the initiation of immune response, and I think that's a great example of it. So when you get an infection in your fingernail, how do you know it's infected? What are the signs? It hurts, painful. What else? It's swollen, and what else? And it's red. You could give the lecture. So this is probably what it looks like initially. You may not be projecting well, but you see it's nice and red and swollen, so it's painful. Why is it painful? Because the blood vessels that supply that area are now dilating. They're getting larger. Well, when things expand and there's not enough room, it becomes painful. Well, why are they getting large? To increase the blood flow and blood supply to that area. It's red. Again, increased blood flow makes it red, and also it tends to be warm from the increased blood flow. And why do you have that? You also have swelling. And again, why is it swollen? Because you have increased permeability of the blood vessels, and now you have a fluid leaving the blood supply, getting into the local tissue. Now, why is this all happening? This is all happening to enable inflammatory cells to specifically localize to that area. The inflammatory cells are in the blood, so you want to increase the blood supply, make it more efficient getting there. You also want them to be able to leave the capillaries into the tissue. Well, if the capillaries are sealed, they can't do that. So you have to open these, you have to increase permeability to now allow them to migrate out, and this is resulting into the symptoms that you have early on during infection. But this is extremely mild infection so far, and in fact, usually this is all that happens. It's like that for a day or two, people have it, and then it just goes away by itself. You don't need to take antibiotics, you don't need to do anything more, because your innate immune system is being very effective at containing this response. However, and so what causes this inflammatory response to occur? Well, the first major cause is a response to bacterial replication. So you have a few bacteria that get into the wound, now they start replicating, and now when bacteria replicate, they tend to damage tissue. So in addition for the actual replication of bacteria to be a stimulus for immune response, also tissue destruction is. Now the opposite of that is if there are bacteria in the body and they're not damaging tissue, the immune system has a détente with those bacteria. We kind of make a deal. You don't bother us, we won't bother you. Now, where does that happen? In the gut. Our gut is loaded with bacteria. And yet, do we mount a potent immune response against those bacteria that we call commensal bacteria? We don't. In fact, they're actually good for us, because if it doesn't harm us, we won't harm you. However, once bacteria start replicating and damaging tissue, that's when the immune system says, whoa, now we have to mount an immune response because you've broken that treaty with us, and if we don't do something, you're probably going to cause significant damage to us. So again, it's not just the bacteria being there, it's also tissue damage, tissue destruction that causes immune responses. But in addition, tissue damage in and of itself can cause an immune response because you need to mobilize an inflammatory response to repair the tissue damage. And the major effector molecule, a cell in this, is macrophages, and macrophages, as I'll discuss in more detail, release mediators to allow recruitment of these cells to the local area of infection. Now, what is the goal of the immune response? You have to have a goal. What does it want to accomplish? First, it wants to prevent the initial establishment of infection. It basically wants to get there, eliminate the bacteria before it could establish a beachhead. That's the most effective thing it could possibly do. However, failing that, it wants to prevent spread of infection from the invasion site. So I always think of like all these, anyone ever see one of these submarine movies? You know, so like, let's say there's like a torpedo, it blows a hole in the submarine. What do the sailors do? They seal the hatch. They go, you know, crank it and close it, because that way you contain the water so it doesn't spread throughout the submarine. The immune system does exactly the same thing. It gets those cells there, and it wants to localize the bacteria so they can't spread into the body. Now, if you aren't successful in doing that, so if this is what your fingernail looks like now, because it's spread, and you can see you don't have tight margins here anymore, it's very, very swollen, the entire finger is swollen, you have not contained the infection. Well, now what do? Now is the time that you recruit effector cells for assistance because the local cells can't deal with it. And at this stage, you probably need to mobilize B cells and T cells. The innate immune system, the macrophages, are not sufficient to contain the infection, and that's when you call in B cells and T cells in order to mount the immune response. So again, conceptually, innate immune response, macrophages are the initial first responders. Invariably, they're very effective in terms of containing infection and eliminating it, but if they're unable to do it completely, they must need to have the capacity to communicate with the B cell and T cell immune response and mobilize them when appropriate. Is that clear? Now, the innate immune response, as we discussed previously, is a layered response. You have multiple layers, and again, as it's kind of like you have code yellow, code red, and whatever. You have different ways of mounting the response. So if you have, let's say you pick your nail and you basically have scrubbed your finger down with alcohol before you've done that, because you're an infectious disease expert and you know that's the best thing to do, you know, that's when you know someone's paranoid, when you see them like wiping down their finger with alcohol wipes before they pick their nails. But anyway, what that accomplishes is the bacterial load in the skin is not that high. So therefore, even though there's a break in the skin, there's not a lot of inoculation, and therefore there's probably, at best, low-level infection, and you have preformed non-specific effectors located in the scanned area, they can remove the few bacteria that come in, and it won't get red, it won't get swollen, there absolutely will be no signs of any kind of infection. It's very, very effective. However, let's say the bacterial load is a little bit higher, and therefore now you have a larger inoculum. Now you need to still use your innate immune response, because again, this is what's responding immediately after the exposure to the antigen, but now it has to be a more complex innate immune response. Now, as I'll go into a little bit more detail, you recognize microbial-associated patterns expressed by bacteria. These now activate these macrophages, make them more effective. They secrete factors that also recruit more macrophages, more innate responding cells. And again, if this is effective, then you remove the infectious agent. Maybe it'll be red and swollen, but you've cut it off at that stage, and it's really not that serious at all. However, sometimes, as that dramatic picture showed, it's not enough. The innate immune system can contain infection completely, and therefore now you have antigen gets transported to the lymphoid organs, to the lymph nodes. As you know, that's where the B cells and T cells are sitting there waiting to see the antigen they're pre-programmed to recognize. That antigen now stimulates the B cells and T cells to differentiate, and now they need to migrate back to the finger to eliminate the infection. And again, we'll discuss later, how do the T cells know when they leave the lymph node where the infection is to go to the infection and clear it. But again, this is just showing that when it's, if it's a low-level inoculum, you could clear it without even knowing you've been infected. A higher level, you still can use your innate immune system to clear it, but if it's a significant, a specific virulent bacteria, a large inoculum, then you need to recruit the B cell and T cell acquired immune deficiency, B and T cell acquired immunity in order to eliminate the infection. Okay, any questions? Now, this is just all to illustrate that here's your finger, that's where the infection is going on. Where are the B cells and T cells sitting? They're sitting all the way very distal from the site of infection. So two things need to happen. The first thing that needs to happen is that antigen present from the pathogen needs to be transported to the lymph nodes wherein it could interact with the antigen receptors on B cells and T cells. That's phase one. The second phase is once they've been activated, particularly T cells need to leave the comfort of the lymph node, get into the circulation, and then migrate back to where the site of the infection is. And again, that's a two-phase process. Again, I'll discuss the details as the lecture progresses, but that's what you should think about. How does this occur? Both how does antigen get to the lymph node, and then how does the T cells get back to the site of infection, as well as macrophages in the innate immune response. Now, I personally like thought experiments, and the reason is they're very cheap to do. They don't cost a lot of money, you don't have to use a lot of supplies, and also you can do them anywhere. So you're waiting in some queue somewhere, you have nothing to do, you can think of these thoughts. So if all of a sudden, poof, this angel appeared in front of you, and the angel said that you've been not the best person in the world, so I have to punish you. And your punishment is that you have to give up one limb of your immune system. And again, this angel, probably is, has some immunological issues, but I mean, who would ever think that? I don't think any fable exists that this has ever happened in history, but maybe we'll start a new fable. So you have two choices. You can give up the innate immune response, macrophages, complement, or you can give up the adaptive immune response, B cells and T cells. So now the angel is making you make a choice. So who here, and again, everyone has to vote. You have to decide. And again, I guarantee you there's no angel in the back that's going to go poof, and you're going to lose that limb of the immune system. But who here would say, I'll give up my adaptive immune system, these macrophages, not too bright, phagocytic cells, because my B cells and T cells are so important? Raise your hand. Who's giving up innate immune system? Raise your hand. Just raise it. You got to vote. Okay. Who here is giving up adaptive immune system? Raise your hands. Wait, you're not, you got to vote. You're not voting. Okay, come on. What? You're keeping both. That's not an option. This is like, angels are mean. They'll say, you know what? I'm taking both. You know, you have to give one. You know, sometimes in life you need to make choices. So who here is going to give up adaptive? Raise your hand. Okay, and who here would give up innate? Raise your hand. Okay, that's fair. So now we've done the thought experiment. Let's do the real experiment. And it turns out, if you look at the y-axis is the level of infection, and the x-axis is how long the infection has gone on. So if you look at a normal immune response, this is in mice and in humans, initially you get infected, you have a level of replication of the bacteria, for example, but then your immune system kicks in, and now you eliminate the infectious agent, and then you've cleared the infection. If you knock out the adaptive or acquire the B cell and T cell immune response, so for example, a skid mouse or a rag knockout mouse, what you see is that you get level of replication, it plateaus, it obviously doesn't get cleared, but it incrementally increases slowly over a period of time. However, if you knock out the innate immune system, look what happens. You don't even control it. It just ramps up very, very rapidly. And in fact, these mice die very rapidly. And this is an incredibly important experiment because it's very instructive. Because what it's teaching us is that what is the more important immune response? The innate immune response. Because if you knock that out, then you really rapidly succumb to infection. And so, in fact, now you've learned something very important. If the angel does appear to you, then you're in trouble. But give up your adaptive immune system and keep the innate immune system. But it's incredibly instructive because this is teaching us that this early response, this ability to wall off the infection, to hold it in check until the adaptive immune response can be mobilized, is so critical and even more important than in protecting us from infection. Now, this is actually very interesting because this thought was used to think in terms of how to treat bioterrorism. In the United States, we had these attacks with, they send spores in the mail to actually senators. If you ever want to get mobilization in terms of funding for research, attack senators, that seems to be the case. But very rapidly, bioterrorism became an issue, and the question was, well, if there's a bioterror attack, how do you respond? Well, one approach would be to, vaccinate, that's what we do, right? Well, how long does it take for a vaccine to start working? Week, 2, 3, 4 weeks. Well, by that time, unfortunately, you may succumb to infection. So therefore, the question was, can we rev up the innate immune system? And in fact, that's an approach that individuals are talking about doing, namely to harness the innate immunity to potentially give people a shot to actually activate their macrophages very, very rapidly, and therefore to help contain infection. And again, this is still in the experimental phase, but at least this paradigm of vaccinating to crank up the innate immune response is something that really is being applied based on the understanding of how important the innate immune system is. Now, the innate immune system is actually fairly intelligent. It may not have the sophisticated antibody molecules or T cell receptors that B cells and T cells has, but it still has receptors that are able to recognize the presence of a pathogen. And the kind of receptors they utilize are very different from those used by B cells and T cells. So in terms of the characteristics, this is comparing the innate immune system to the adaptive immune system. The specificity is inherent in the genome. For innate immune system, it's absolutely yes. The full gene encoding the receptor is there. It does not need to undergo rearrangement. It's expressed by all macrophages. So as opposed to adaptive, where each cell recognizes a different antigen, all the macrophages will recognize the same pattern. It triggers an immediate response, so a very rapid response. It can recognize a very broad class of pathogens, a range of bacteria or viruses, whereas the adaptive immune system is incredibly specific. And it interacts with a range of molecular structures, whereas the adaptive is highly focused on only the specific antigens pre-programmed to recognize. In contrast, the adaptive immune response, encoded in multiple gene sequences, we'll go into that in more detail, requires very complicated gene rearrangements to make B cell and T cell receptors. You have the clonal distribution, one cell, one antigen specificity, and it's able to discriminate incredibly subtle differences in structure that may distinguish between a self-reactive antigen versus a pathogen-specific antigen, whereas the innate immunity is more broad-based and not as finely tuned to be able to make those subtle distinctions. But at the end of the day, it's this quick and dirty, low-tech system that allows us to mount a rapid immune response that, as you see from that experiment, is so critical in our survival from infection. Now, as I mentioned previously, the critical aspect of the innate immune system is that it uses barriers that protect us from exposure to pathogen. So skin, as you know, when it's intact, it's actually very, very protective. These are fixed barriers. They don't get better when it's been exposed to antigen. So you could wipe your skin with bacteria from today till tomorrow. It's not going to become better at protecting you. However, your adaptive immune system, B cells and T cells, as I mentioned before, does improve with antigenic exposure. The more times you see the antigen, the more rapid the response is. The innate immune system pretty much stays the same. Now, in addition to the skin, another critical component of the immune response, of the innate immune response, is the gut, particularly your stomach. So your stomach, you have very high levels of acid in your stomach, and this acid gives you low pH, and that destroys, for the most part, almost all bacteria, for example, that you would ingest. Some are actually that can be resistant, but for the most part, it's very effective. And the experiment that happened to me many, many years ago was with my wife and my oldest son. So anybody here have kids? Okay, so if you have a 2-year-old child, right? You go into your car, and do you kids like raisins, eat raisins? Any sticky stuff they like to eat? Marshmallows, great. So that you put them in the back seat of the car, they see a marshmallow on the floor. And the marshmallow is loaded with all sorts of dirt and gunk. And what's your child going to do? He'll pick it up, now what's he going to do? Put it in his mouth and swallow it, right? I mean, that's what kids do. So, same happened to me. My kid went into the back seat, and he hones in on this disgusting raisin, pops it into his mouth, and swallows it. And then my wife looks at me, and he says, Harris, look what he just did. He swallowed it. He's going to die. You know, that was in the backseat of the car. Who knows what's growing on that raisin? You know, this is the end. What are we going to do? And we go to the emergency room. We should pump out his stomach. You know, what do you do, right? You're a parent. And then she said, you're a doctor, right? So you have to do something. So, you know, I'm thinking, what should I do? And then I realized, wait a minute, I'm an immunologist. So I said to my wife, you know, honey, there is acid in the stomach, and the pH is very, very low, and that'll destroy any potential bacteria that may be in that raisin or marshmallow that I eat, and there's really absolutely nothing to worry about. And meanwhile, I'm thinking, I hope he doesn't get a fever. I hope he doesn't get a fever. I hope he doesn't get sick. And sure enough, you know, he was fine, no problem at all. And again, all of us have survived our childhood because of our stomach pH. The innate immune system is so critical in protecting us. We have similarly, in the lungs, we have cilia that continuously beat to help clear any inhaled pathogens that we come in contact with. And our eyes and nose, again, our tears, cilia, and saliva all have chemicals in that break down bacteria, lysozymes, for example, all of which protect us. And as I mentioned previously, we have commensal flora that are present in our gut that also protect us from being overgrown by pathogenic bacteria. So we all know, for example, if someone's been on antibiotics for a while and you knock out your commensal flora, actually those individuals can now go ahead and get super infected and get diarrhea and other GI infections because you've eliminated this kind of protective barrier. Okay, any questions? Now, the first step in terms of the infectious process is that you have adherence of bacteria to the epithelium, and they're just waiting there for an opportunity. As long as the skin barrier is intact, nothing's going to happen. They're not going to be able to infect you and cause disease. Waiting behind the scenes, we have tissue macrophages that are present. We have dendritic cells I'll discuss in greater detail. called Langerhans cells that are present waiting, but this is kind of like the calm before the storm. Because if there's a break in the barrier, so let's say a person cuts themselves and now they've introduced bacteria under the epithelium or the epidermis, and now the bacteria gets introduced into a localized environment. Well, if the inoculum is very, very small, then pre-formed proteins, phagocytes that are present there will eliminate these bacteria before they're able to cause significant level of infection. And in fact, you probably won't even realize, like every day you cut yourself, you basically put on a Band-Aid, and you don't ever get infected because this is working very, very well. However, if the particular bacteria that gets in there is a very virulent, rapidly replicating bacteria, or the inoculum is very, very high, then now when it gets into the environment, you have high level of replication, high level of tissue destruction, and now you need to recruit a much more rapid, larger number of macrophages and potentially dendritic cells in order to help contain the infection. And again, you're trying to contain it and preventing it from spreading. You can see that there are some macrophages being recruited from the peripheral blood, diapodecing through those leaky capillaries, again, to help provide reinforcements to the innate response to help control and potentially eliminate the infection. However, in addition, also you can have induction of blood clotting to prevent spread of the infection into the peripheral tissue. However, if this is unsuccessful and the replication is so vast as I showed before, now you need to recruit adaptive immunity. Antigen goes into the lymph nodes, recruit B cells and T cells, they undergo proliferation. T cells now, you see they're physically being recruited into the area, predominantly the helper cells for the most part. And in addition, antibodies that are secreted by B cells in the lymph node get into the circulation. Again, because the capillary is leaky, it allows them to more efficiently leave. And now these antibody molecules will bind to the bacteria, and now they'll eliminate it either through facilitating phagocytosis or with complement mediation, and T cells will stimulate the capacity of phagocytic cells to be effective. Now, I mentioned before that phagocytic cells have to express receptors that have the capacity to recognize that a pathogen is there. So instead of having, again, a sophisticated antibody molecules or T cell receptors, it has receptors that recognize motifs that are known to be present in bacteria that they could now recognize that there's an infection going on. So if you look at, and each one of these factors has the commensurate receptor on the surface of the macrophage. So for example, bacteria have very, very high levels of glucans in their cell walls. Our cells don't have cell walls, so we don't have glucans. So therefore, we have a glucan receptor. If the macrophage sees glucan around, it knows it's from a pathogen, therefore it's able to bind to it. Bacteria have high levels of mannose present in their surface. We don't. Therefore, mannose receptor is specific for these moieties. And lipopolysaccharide, something almost all of you are familiar with, LPS, is present in gram-negative bacteria. And again, we have a receptor called CD14 that interacts with another receptor called toll-like receptor, or TLR, in this case 4, that now recognizes LPS and activates the cell. Now, toll-like receptor is this actually incredibly cool discovery that was discovered from fruit flies. And again, for the most part, who here would ever think that we would learn about immunity from a fruit fly? You know, mice, yeah, it makes a lot of sense, but fruit flies, well, it turns out that fruit flies are very easy to mutate. They have a very, very rapid gestation, so within a few hours or maybe less than a day, you have a whole generation of fruit flies. So geneticists love fruit flies. So they basically knock genes out all the time in fruit flies and then ask the question, what does that gene do? So it turned out they knocked out this toll gene. They had no clue what it was. They just knocked it out and they said, let's see what happens. And it was discovered in 1996, and it was a developmental gene in Drosophila. However, what was very, very dramatic was that when they knocked out the gene, the flies developed massive fungal infection. Now, has anyone ever seen a fungally infected mouse? I mean, a fly? No, I mean, probably the fly dies before the fungus can replicate enough to infect it. Yet, look at what the flies look like. This is a scanning EM of a fly. You recognize the eye. But what is all this hairy stuff over here? This is all fungus, because these flies lacked this toll, and apparently this was encoding what a critical fly immune response, which turns out to be very, very innate, and lacking that, they became infected. So now individuals said, well, if toll is playing a role in fruit flies, let's look for the human homologue and see if we have toll. And it turned out we do, and it turned out that toll, the family, encoded an important immune molecule, and that's why it's called toll-like receptors. That our receptors that we have are very similar to the ones that Drosophila uses, a little bit more sophisticated, but conceptually exactly the same. So this discovery all evolved from studying fruit flies. And so now the bacterial-derived factors, LPS, binds to CD14, toll-like receptor, mannose receptor, and glucan receptor. And sometimes immunologists are your friends. So they name things in a way that makes it easy to remember. So if someone asks you what binds to the mannose receptor, that's pretty easy, right? What binds to the glucan receptor? That's pretty easy. They didn't call it CD29, or they didn't call it like Joe's receptor. They gave it a name that allows you to remember what it was. And now toll-like receptor, just think of that fruit fly that's infected with fungus. And now if you look at it at the cellular level, the macrophage has these preformed receptors, mannose receptor, glucan, LPS receptor. If there's no infection, they just basically sit there doing nothing. And here's the toll-like receptor. However, if there's a bacterial infection, now what happens is the bacteria expresses on its surface mannose, for example. It binds to the mannose receptor. This triggers signal transduction in the macrophage, causing it to release cytokines and chemokines to recruit other macrophages. Or in this case, LPS binds to CD14. It now associates with toll-like receptor, and again, activates the macrophage, make it more and more effective in terms of its ability to kill. And now the macrophage is able to ingest the bacteria. It's activated, so it has a lot of phagolysomes which merge and kill it. In addition, it secretes cytokines and chemokines that serve to recruit other macrophages into the localized area to help it in terms of clearing the infection. Again, so therefore, the binding of the bacteria itself to these specialized receptor is enough to trigger activation of macrophages in the complete absence of T cells. Is that clear? So a macrophage goes from being quiescent, not doing anything, to being activated, solely being activated by the presence of these bacteria because of these specific receptors. And this process can turn on a whole host of genes, and in this case, LPS binds to CD14, and then it now associates with toll-like receptor. And toll-like receptor actually uses a transcription factor, NF-kappa B, which many of you have heard of, in terms of activating a whole host of genes to turn on the appropriate cytokines and chemokines to really initiate the immune response. So this capacity to specifically recognize these motifs that are present in pathogen allows the innate immune system to activate itself in the complete absence of T cells. And there's a whole range of toll-like receptors. Each one of them has specificity for different compounds or molecules that are derived from different pathogens. So for example, gram-positive bacteria have triacetylated lipoprotein, diacetylated lipoprotein, and they're recognized by toll receptor 1, 2, and 6. Flagellin is present in some bacteria, recognized by toll receptor 5. In addition, some of these toll receptors can be activated by viral infections. So the innate immune response is not only extracellular for bacteria, there are also toll-like receptors that are present inside of cells, in the nucleus, that can activate the cells after infection with the virus and make the cell make interferon alpha that allows the cell to basically protect itself from viral infection. So it turns out that CpG DNA, which is present highly in viruses, can bind to TLR9. Double-stranded RNA, which again is present in retroviruses, for example, can activate TLR3, and again, allowing the cell to protect itself from infection in the complete absence, potentially, of a T cell response, the innate first-line immune response. Okay, so it's a lot more complicated than people initially thought. But again, the initial insight was by seeing fungally infected fruit flies. Okay, any questions on that? So people,
Excuse me?
yeah.
In the absence of toll-like receptors, is there any other mechanism that these innate system can recognize a pathogen?
So the question is, in the absence of toll-like receptor, is there other mechanisms? And yes, because the mannose receptor, the glucan receptor are not toll-like receptors, and then that's another way of recognizing it. But clearly, toll-like receptors are critical for a wide range of pathogens. So if you knock out toll-like receptor but still have mannose and glucan, you're compromised, and you'll get sick, but not as bad as completely knocking out your innate immune system. Now, does this have relevance to HIV? Well, if you think about it, you probably think, no. Why would, T cells basically are CD4 T cells are infected with HIV? That should not have an impact on the immune system. In fact, Marcus Atfeld, who actually I know visited here a while ago, had a paper in Journal of Virology 2 years ago where he basically reported that HIV actually encodes toll-like receptor ligands that bind to macrophages and activate macrophages. Well, does that make sense? Why should HIV want to activate macrophages, right? You think that a pathogen would want to turn off an immune response, not activate it. Why? Would anyone have any suggestions? Why would it want to activate it? Yeah.
The virus is an intracellular organism or entity, and it tries to get into the body. So it just uses this as a taxi by going into the macrophage and then being moved further.
Okay, and let's say you have the virus that's already infected the macrophage, but the macrophage is quiescent. Is there going to be efficient replication of the virus in a quiescent macrophage?
Probably not.
Probably not, because there's not a lot of proteins being made. So what the virus would want would be to activate the macrophage, to rev it up, to have it make a lot of proteins, and now it can make a lot of virus. So even though it's counterintuitive initially, it actually makes sense why HIV would want to activate, in this case, macrophages to make them a factory for making virus. And in fact, it can do the same thing for T cells as well. But it's interesting that HIV has actually harnessed this innate immune response, toll-like receptor, to activate macrophages to make more virus. Again, one of the many examples of how HIV has hijacked our normal immune response to allow it to become a more efficient and more effective pathogen. Now again, to shift back to the innate immune system, clearly a critical issue is how does antigen get from the periphery to the lymph node? What is the bridge between the innate immune system and the adaptive B cell and T cell immune system? And it turns out that Langerhans cells, which are present in the skin and in the mucosa, provide an important link between the innate and adaptive immune system. So basically, immature dendritic cells are present in the skin. After activation, they migrate from the skin to lymph nodes and transport skin-derived antigens that are coming from pathogens from the infection inside the skin. And in the lymph nodes, now they become activated dendritic cells, become very efficient antigen-presenting cells. Again, I'll be discussing this in greater detail in subsequent lectures, and now activate antigen-specific lymphocytes. And then, again, these cells are the way that the innate immune system activates the adaptive immune response, how the innate immune system talks to the adaptive immune response. And pictorially, what you could see, for example, is that here's a Langerhans cell that's present in the epithelium or epidermis. And in this case, it's been infected with a bacteria coming in through a break in the skin. It binds, in this case LPS, CD14, recruits toll-like receptor 4. This now activates the Langerhans cell. When the Langerhans cell is activated, it now knows it has to migrate from the skin into the lymph node, so it then goes into the draining lymphatics, it gets into the lymph node, and here in the lymph node, it differentiates into a very highly effective antigen-presenting cell, and as discussed in the next lecture, expresses MHC molecules, and now it's able to present antigen from this bacteria that is digested, both to T cells as well as to B cells, to mobilize them to then now could go back and fight the infection. So again, this is the critical bridge between the peripheral tissue and the lymph node that enables recruitment of the adaptive immune response. Is that clear? Any questions? Now, in addition to having these receptors that are pattern motif recognizers. The innate immune system also has soluble factors that have the same function. So the same way that B cells make antibodies that are very highly specifically recognize pathogenic antigens, innate immune system has soluble factors that also recognize the same kind of pattern motif. Again, a quick and dirty approach to recognizing pathogens, but one that allows you to have very rapid response because you have these present all the time in the body. And again, the same way you have a mannose receptor, you also have a soluble mannose binding lectin. You have a C-reactive protein which binds to motifs present. And again, this is actually interesting for people who are infectious disease people or physicians, because one of the earliest signs of infection that you could use to monitor infection is C-reactive protein. Why? You get infected, you trigger your innate immune response, it makes its soluble factors to protect itself. One of them is C-reactive protein, and it's actually a clinical test. You actually test patients for C-reactive protein to determine if they have a bacterial infection. And in this case, for example, the C-reactive protein binds to phosphocholine, which is a compound present on bacterial surfaces, and allows it as an opsonin. It makes it more effectively engulfed by macrophages, or mannose binding lectin binds to mannose, again, also linking the soluble factor, making the phagocytic cells that much more effective in ingesting it. Okay, is that clear? So again, the innate immune system really has mirrored what the adaptive immune system has, with antigen specificity receptors on the surface of cells, as well as making soluble factors that also recognize these patterns. Now, once monocytes have been activated by pathogens, it makes a whole host of cytokines and chemokines designed to both recruit new T cells, B cells, as well as other macrophages, activate macrophages, and also trigger a range of, I think the battery has died, but to range if you have a wind-up one, that probably works better. But to compartmentalize the infection and localize it so it doesn't spread. So to focus, for example, on tumor necrosis factor, that's a compound that we're very familiar with clinically. And at the appropriate doses, tumor necrosis factor is very, very important, because what it does is local infection with gram-negative bacteria. So now you've infected the skin over here. You want to localize it, so you have release of plasma proteins. TNF, for example, makes it leaky, allows the phagocytic cells to leave the capillaries to the local area of infection. In addition, you have little small clots that you introduce to prevent the bacteria from getting into the bloodstream, leaving and giving you infection in your bloodstream and going to distal sites. That's the appropriate job for tumor necrosis factor. It's doing good. However, what happens if you make too much tumor necrosis factor? That is potentially fatal and causes what we know as septic shock. So too much tumor necrosis factor, well, now you have open capillaries throughout the body. If you've open capillaries throughout the body, you've basically depleting the blood volume because you get swelling all over the body. Therefore, you don't have enough blood to pump, and you go into shock. Your blood pressure dramatically gets lower. You get inflammatory cells leaking out throughout the body, causing damage throughout the body. And in addition, you have development of clots. So you have coagulopathies, you have clots that are preventing the perfusion of critical tissues, for example, the spleen, more importantly, the kidney, going to kidney failure, and in fact, too much tumor necrosis factor is a terminal event that leads to septic shock. Has anyone here ever seen septic shock? It's very dramatic. Now, how would you use this information to come up with a treatment for septic shock?
Well, I mean, I'm not sure. I mean, you wouldn't want to antagonize TNF.
Okay, so you'd want to antagonize TNF, and think of how could you harness the immune system to antagonize TNF. What would you make?
Antibody against TNF?
An antibody to TNF. And in fact, you could inject, pick your method of choice, make monoclonal antibodies against TNF. Person goes into septic shock, you give them antibodies against tumor necrosis factor, it sequesters it, it stops the whole process, and in fact this has been used as a treatment for septic shock, giving antibodies for tumor necrosis factor. So again, understanding the underlying immune methodology behind the septic shock allows us to develop therapies to treat those individuals. So again, this is an important point, is that immune system is good, but sometimes too much of an immune response can be bad for the patient, and that's why this delicate regulation is so critical in having the immune system work so well. Now, how can effector cells be recruited to the site of infection? Well, first, you have a local site that's infected. It needs to express signals that recruit specific cells that are needed to contain infection. On the flip side, the effector cells need to have the capacity to recognize those signals so they can migrate from the circulation into the inflammatory site. So this morning I had a great example of that, because I was being driven by the person who runs the bed and breakfast I'm staying at to come to this location. We have never been here. So as you know, if you've ever been looking for an address or something, you can drive up and down the street for a long time looking for something and you won't be able to find it. You need that familiar thing to hang on to pull you in. So we're driving around and then we see Victoria waiting out there for us, and we say, oh, that's our recognition molecule out there. We know that the car should screech to a halt, stop, because this is the right place for us to be, and it's a combination of both. You basically, she was providing the signal that this is the right place to come, and we were the effector cells looking for the signal to tell us that's where we should be coming. And this same thing happens for infection. Now, in order to recruit cells, you need to have a whole host of chemokines, and this used to be a very simple field 10 years ago, but now you can see there's a whole broad range of chemokines that are being produced by macrophages and other cells. This gives you a list of what cells make them. This gives you a list of what cells are specifically attracted by these chemokines and what effect they have. And again, this allows the specific and focal recruitment of different populations of cells to mount the appropriate immune response. And again, we'll discuss in the HIV lecture that, as almost all of you know, HIV has utilized this as a co-receptor for HIV. So HIV can utilize CCR5 as well as CXCR4 as its co-receptor. So it's, again, another example of how HIV has co-opted our normal immune response in order to enable it to be more efficiently effective. But again, this is incredibly complex. This is the innate immune system, yet by having different chemokines made by different cells, you could focus recruitment of a very, very tight, specific population of cells to give you the appropriate immune response for whatever pathogen is initiating it. Now, how do cells get mobilized to that area? They have to stick. And in order to stick, they have to have adhesion molecules. And this is actually an incredibly complicated field, but in a simplistic point, just appreciate that you have basically the one molecule is expressed, and that molecule can bind specifically to another molecule that serves as its ligand. So in this case, this is showing you P-selectin, for example, binds to Cialis, which I'll discuss in a few minutes. LFA1 is a very, very important adhesion molecule, specifically binds to several molecules, but predominantly the one we'll focus on is ICAM. And again, this is another example of how immunologists are your friends, because ICAM stands for intracellular adhesion molecule. So whenever you see AM at the end of an immunological word, the chances are very high that it represents an adhesion molecule. So again, if you see ICAM, intracellular adhesion molecule, LFA1, you weren't as lucky, so sometimes you just have to memorize that. But LFA1, ICAM, is a very, very important interaction between two adhesion molecules that's utilized through multiple motifs in the immune response. But you need to, therefore, have a way of getting the cell to stick. So in fact, Victoria served as our adhesion molecule, because we recognized her, she recognized us, and then, boom, we bound, and then we came into the Nelson Mandela University to the right lecture hall. So it actually worked very, very well. This is just showing you ICAM1, and it's expressed at high levels on activated endothelium. When endothelium is not activated, there's no ICAM1, or very low levels are expressed, only after it's been activated. And ICAM1 binds very efficiently to LFA1. Well, how can we put this together in order to allow us to understand how infection focuses inflammatory cells to the site of infection? Well, the first point to appreciate is that inflammatory cells, macrophages, neutrophils, even B cells and T cells, they express adhesion molecules. So in this case, they express high levels of LFA1. And LFA1 is very efficiently going to bind both to ICAM2 as well as to ICAM1. And therefore now, if there's a site that's expressing high levels of ICAM1, and the macrophage is expressing high levels of LFA1 because it's been activated, sticking will occur, and that'll allow specific targeting to that area. So now, if we think in terms of what happens normally in the bloodstream. So normally, think of the bloodstream as a highway. Now, if you needed to, let's say you were picking somebody up on the sidewalk, and you didn't know where they were. You knew they were within like a 10-block area. Where in the highway would you be? Would you be all the way in the fast lane in the center of the highway? You know, if it's a 6-lane highway, or would you be adjacent to the sidewalk in the slower lane? Where would you be? Anybody? In the slower lane. Because if you see the person and you're in the fast lane, and you have to cross over 3 or 4 lanes of traffic. You know, you won't be picking up that person. That's for sure. So that's what you would do. Well, think about the bloodstream. The blood is basically circulating in a very large blood vessel. The possibility exists that your circulating macrophages may need to diapodese into the local tissue because there's an infection. If those white blood cells were in the center of the bloodstream, how efficiently would they be able to quickly veer off into a site of infection? Not very efficiently. So there has to be a mechanism to allow macrophages to maintain their proximity to the vascular epithelium to be ready to dive into a site of infection. The way this is done is by having the expression of these low-level affinity adhesion molecules between the phagocytic cell and the endothelium. In this case, you have Cl-Lewis expressed on the surface of the phagocytic cells and E-selectin expressed on the surface of the endothelial cell. This is another example of why immunologists are your friends, because E stands for endothelium. So E-selectin is the kind of selectin that's expressed in endothelial cells. The interaction between these adhesion molecules is not very strong. So think about kind of like Velcro, or those stickum notes. You put it against the wall, take it off, put it on. It's enough to stick, but it's not as permanent. And therefore, what happens is that the phagocytic cell rolls along the surface of the endothelium. It doesn't get stuck in one spot, but it's enough to moor it to the side of the endothelium. So therefore, if there's any signs of infection, it could rapidly dive in. So now, let's see what happens when there's an infection. So now, again, you've had a break in this case, your epithelium. You have an infectious process going on. Phagocytic cells now have been activated by binding of the pathogen to their motif recognition receptors. They're secreting chemokines. Those chemokines now are getting into the circulation. In addition, they're making cytokines that have an effect on the endothelium, making these endothelium cells now express high levels of ICAM1 molecules. In the absence of infection, they're not being expressed, but now that it's infected, they are expressed. And in addition, tumor necrosis factor also being made by macrophages is making the epithelium leaky. So therefore, the cell-to-cell junctions aren't as tight, and therefore you can get diapodesis of the cells. So now if we put everything together, in this case, interleukin-1 diffuses into the circulation. The macrophage is rolling along the Cl-Lewis and E-selectin. However, the IL-8 activates the phagocytic cell. It may upregulate LFA1 expression. Now, this macrophage comes down on an ICAM1, which is being expressed because of the infection, the inflammation. It binds tightly to the ICAM1. Once it binds to the ICAM1, it stops. It grinds to a halt. It's like, you hit the brakes, you're going, and stops. And now once it stops, it now sees, oh, there's a leaky membrane. I could diapodese through it. It's being drawn by the gradient of the chemokine into the tissue here, and now it comes in, and now it could be a phagocytic cell. And this is the effective way how all these phagocytic cells are rapidly localized to the area of the infection. The ICAM1 is expressed, it flags it down, chemokines are expressed, and it draws it in through a gradient, and now this is how you rapidly can recruit inflammation to the appropriate site of infection. If there's no infection, no ICAM expression, no chemokines, the macrophages keep going on. Does that make sense? Is that clear? Very, very elegant system. Okay, now again, HIV is amazing in its ability to take advantage of the immune system. So HIV wants to stick to cells in order to infect cells. So when HIV buds from the membrane of T cells, for example, it can actually take ICAM1 with it. So in addition to expressing GP120, which as you know is going to bind to CD4 and CCR5, HIV says, you know what, I'm not proud, I'll take another sticky molecule, I'll take ICAM1. So now HIV has ICAM1. So now HIV comes to a cell it wants to infect. In addition to being able to bind to CD4 and CCR5, now it can bind to LFA1. So in fact, you actually amplify the ability for HIV to infect a cell by virtue of its co-opting this adhesion molecule, and allowing it therefore to be, in this case, showing that expression of expression of ICAM1 by viruses, it amplifies its ability to infect. So again, HIV has co-opted this adhesion molecule approach that we utilize by the innate immune system to stimulate and increase its ability to be infectious. So basically, the questions that I posed at the beginning of the lecture was how can the immune system detect invasion by pathogens and alert the immune system? We discussed the innate immune system, how it's there, it's present at the front lines where infection can occur, and that plays a critical role in the first step. It uses pathogen profiling by expressing receptors that recognize motifs that are uniquely expressed by bacteria, also secretes factors that are that recognize motifs that are uniquely expressed by pathogens, and that in and of itself binding to it can activate the cell and therefore allow the immune system to contain the pathogens by recruiting the innate immune phagocytic cells to allow it to engulf the pathogens before they have a chance to spread. Plus it makes factors like tumor necrosis factor that seal off the local blood supply to help also contain the pathogen and prevent spread. And the way that the immune cells are directed to sites of infection is by selective expression and upregulation of adhesion molecules at the site of infection, as well as ligands for those molecules by the inflammatory cells themselves. And if all else fails, using Langerhans cells allows it now to bring in the adaptive immune response to really help clear the infection. So again, I think if the angel comes to you, don't forget, keep the innate immune system. It's a very important part. Again, thank you very much for your attention.